everyone, and welcome back. As a reminder, this is the Insight podcast. Insights is a podcast that is diving into sort of neurocritical care for a general intensivist, for our trainees, and helping to kind of bring exposure to neurocritical care topics for all. As a reminder, we are so grateful for our sponsors, Biogen and Cerebell. And now we have a word from our sponsors before we dive right back in.
Founded in 1978, Biogen is a leading global biotechnology company that has pioneered multiple breakthrough innovations, including a broad portfolio of medicines to treat multiple sclerosis, the first approved treatment for spinal muscular atrophy, and 2 co-developed treatments to address a defining pathology of Alzheimer's disease. Biogen is advancing a pipeline of potential novel therapies across neurology, neuropsychiatry, specialized immunology, and rare diseases, and remains acutely focused on its purpose of serving humanity through science while advancing a healthier, more sustainable, and equitable world.
The acute phase of acute ischemic stroke last time, and we talked about how we focus on thrombectomy and thrombolysis interventions such as alteplase versus tenecteplase and all those cool things. But beyond a stage, really, the idea is what to do to reduce the recurrence and all the complications that can happen after this acute phase of stroke. So today we're going to focus on all of that. What's going to happen after that acute phase of ischemic stroke, and how can we minimize all the complications? So Casey, with that in mind, when you're admitting a patient with acute ischemic stroke to your ICU, what are some of your considerations?
So when I think about kind of how we're going to tackle this admission, I think there are kind of 3 things to really think through. The first is just kind of blood pressure control, which is mostly the most applicable thing in the first 24 hours. So we'll talk a little bit about how you manage that. The second thing I have to sort of think about is, is this a large stroke, and is this someone who potentially might need surgical intervention? So we'll talk about that. And then finally, it's kind of figuring out like, why did this stroke even happen? And like, what medications are we going to put on board to prevent a reoccurrent stroke? And so to start with sort of the blood pressure goal, we know from the ASA guidelines that anyone who gets lytic therapy, the blood pressure goal after you get either alteplase or tenecteplase needs to be less than 180 over less than diastolic of 105. And so I think a question was in the literature, like, is lower better? Like, if what we're doing is trying to prevent a reperfusion injury and hemorrhagic transformation of the stroke, and we think that risk increases with higher blood pressure, is it better to lower the blood pressure more? So Enchanted looked at this. This was a trial that was done some time ago, published in the Lancet in 2019. And basically what it showed is that while we did prevent a couple more hemorrhagic transformations, we actually had no difference in the modified Rankin scale at 90 days with this intensive blood pressure lowering group. So my takeaway from that is that, yeah, maybe we've prevented some like very small hemorrhagic transformation that was probably not clinically significant, but at the same time, we reduced collateral circulation, and our patients who rely on that collateral circulation weren't getting the perfusion that they needed. So I think the answer is, up to 180. If the patient's autoregulating below 180, just keep them there. We don't need to go crazy lowering their blood pressure. The next question that comes up in my practice is, fortunately, with life-saving treatment like lytic treatment, like mechanical thrombectomy in particular, a lot of our patients are not having these gigantic strokes anymore, and that's obviously fantastic. But I would say that there are still a reasonable number of patients that either don't qualify for treatment because they come in so late, or that do get treated, but the treatment's just not successful. And so these patients end up having bigger strokes. The question is which of those patients are going to then develop malignant edema? So malignant edema is, a mix of vasogenic edema, cytotoxic edema, ionic edema that causes the brain to swell. And that swelling, particularly in our young patients, can actually cause herniation and death. So for some of these large territory infarctions, the morbidity can be up. I mean, the morbidity is very high, and the mortality can be up to 80% without any interventions. And so this, I think, is something that we really should be aware of. This is most an issue in our younger patients that have these large territory strokes. So what I mean by that is that they have greater than 2/3 territory of the MCA being affected by early evidence of ischemia. That usually translates into someone having a non-dominant stroke of an NIH stroke scale greater than 15, or a dominant stroke scale greater than 20, right? So big strokes. We know in our younger patient population that that sort of stroke has a very high risk of progressing to herniation. And so Decimal, Hamlet, and Destiny, which were sort of these first generation trials that were done in Europe, looked at randomizing those patients to early surgical treatment. And what they found was decompressive hemicraniectomy done in the first 48 hours. So really ideally before there's any sort of evidence of herniation, like before the patient starting to look sleepy, very much before the patient has a blown pupil, that if we take the bone off and give those patients, room for that swelling to occur going extracranially, we're not only reducing the mortality, we're reducing morbidity. So the amount of patients who had a MRS of 3, that was a much higher percentage of the patients who actually got the decompression. So I always, when I'm talking to families about this, my personal practice is to say that our best chance at giving you the best possible functional outcome is to remove the bone and do this early. Now, I want to be clear that some patients are going to end up still in that sort of disabled category of having these, severe disabilities after their stroke. And so this is a really important time for shared decision making, because some families will say, my loved one wouldn't want to live if they were going to need a trach and a peg and prolonged recovery. That's just not the type of, care that it would be goal concordant for them. But it's really important to have those discussions up front, and to be in a surgical capable hospital, right? So this is one of the big take home points for me, is if you are not in a neurosurgical capable hospital and you have a young patient less than 60 years old who has one of these big strokes, talk early about transferring them to someone that does have a neurosurgical capable facility. The data is really not as robust for our older patients. And so I think that becomes really a case by case scenario. Destiny 2 showed that, in our older than 60 patients, decompressive hemicraniectomy did lead to a mortality benefit, but not so much a functional benefit. And so it really is a discussion to have with your neurosurgeons, to have with family. This is not as clean and clear cut. So we've talked about blood pressure control. We've talked about decompression for large territory strokes. The next sort of thing is trying to figure out why they had the stroke. And we can certainly spend like a whole podcast talking about like different etiologies of stroke, how you work them up. And I think that that's going to get beyond the scope of what we're trying to cover here. So what I wanted to leave you with is that very frequently as an intensivist, you're going to get input from your vascular colleagues, from your neurology consult. I think some of it is just being familiar with what agents they're using to prevent secondary, ischemic events. So Salia, you want to walk us through some of like what you're going to see if you're taking care of these, post-stroke patients?
Sure. Yeah, good point. I think the first maybe clarification here is that sometimes I get questions about, should we put these patients on antithrombotics? And I think I wanted to clarify what that even means, because antithrombotic agents are kind of used as like one phrase without really understanding, as simple as it sounds, what it means. So when we talk about antithrombotic agents, that is this big umbrella of anticoagulants and antiplatelet agents. So and as you mentioned, when these people have these acute episodes of ischemic stroke, almost all of our patients, unless they have a contraindication, they end up on an antithrombotic agent, which means they're either going to be on antiplatelet or anticoagulation. So the question is, who gets what? And can we actually give someone both agents, meaning an antiplatelet and an anticoagulant? So I wanted to take some time to walk us through how we decide and who gets what. I think aspirin is pretty clear cut here. It's the backbone of stroke prevention. We use that obviously commonly for patients with atherosclerosis disease. And it's usually started early on, after you get your stability head CT. The idea is that, yes, we put patients on aspirin, and that seems to be, I think, pretty straightforward. I think when we talk about DAPT, or dual antiplatelet therapy, that's a very gray area in stroke. And what we know as of now is that patients who have minor stroke, or TIA, patients with high risk, if they have a very significant degree of stenosis or high atherosclerotic patients, they may qualify for DAPT. Now, the earlier you start this dual antiplatelet therapy, the better off we are. And by early, we talk about 12 to 24 hours. So in prior trials, we've seen that the earlier the better. And also, the other piece of this equation is that you don't want to keep these two antiplatelet agents forever. So there are, again, studies that saw that if you kept it for a long duration, these patients had higher rates of bleeding. So because of that, the guidelines are talking about limiting it to 21 to 90 days. So
Digging. Celia, how do you approach the fact that there are these sort of clopidogrel non-responders? I feel like every institution has a little bit of a different approach to trying to sort that out, because obviously clopidogrel, while there is more resistance to it, is a much cheaper drug than ticagrelor. And so
yeah, I think, again, that's these cases are complicated. I think what I can say is that we definitely have the capability of sending for P2 Y12 levels. Although I have to say that's never been proven to be as validated in neurocritical care world as opposed to the cardiology world, but it is available. It's an available test, the P2 Y12, to see to measure the amount of platelet inhibition with clopidogrel. And I know that our institution, for example, to this day, we use that and put it, in context with all the other things that are happening. I think what may be honestly even more helpful than looking at those levels is that if your patient was already on Integral and aspirin and they came in with another stroke, I think maybe it's time to think about the fact that they are resistant to clopidogrel, and we have to think about changing that agent. As far as anticoagulation, I think, as we know, putting someone on anticoagulation after acute ischemic stroke is very unique in a sense that these patients usually have AFib. These are patients that are at high risk of cardioembolic stroke. As we all know, putting people on anticoagulation really depends on patients with AFib who have the CHADS fast that require them to be on anticoagulation. I think the bigger question is, when do you put patients on anticoagulant after their acute ischemic stroke? Are you worried about their transformation to ICH? The answer is yes, we're always worried about this transformation. And that's why I think these are very good discussions to have with your stroke team, with your neurocritical care team, and with your pharmacist. But what's been proposed in the guidelines is that if the risk of bleed is high, you really want to delay initiation of anticoagulation for the second stroke in AFib for more than 14 days. So the earliest you want to start in these high risk patients for ICH is to start it at day 14. But if the risk is low, the guidelines, or the American Heart Association guideline, I should say, talk about initiating it between day 2 to 14. So that's just something that's been proposed. Now, where do you pick in that big range of day 2 to day 14? It's really up to your team and your, risk factors for your patient and all the things that I think should be considered. And it should be a multidisciplinary discussion.
the final thing that I think is important when you have an inpatient stroke admission is like a lot of what prevents a secondary stroke is like just modifiable risk factors, right? So actually getting their diabetes under control, actually controlling their hypertension, working with a dietitian to establish better dietary habits, um, smoking cessation, so key. And I think these are often kind of overlooked because behavioral change is really hard, right? It is much easier for us to provide medications than it is for us to induce behavioral changes. But those behavioral changes are actually really what's going to prevent the secondary stroke. Okay, so this was a whirlwind tour of hospitalized acute stroke care. Big sort of takeaway points from sort of a clinical management. Lower blood pressure is not better. Second takeaway point, if you have a patient who has a large ischemic stroke and they are young, less than 60, think early and talk to a neurosurgical capable center really early in their course about decompressive hemicraniectomy. And then we have to kind of come up with like what caused this stroke and pick the right agent. And as Salia went through, there's a lot of complicated factors in choosing, and what antithrombotic agent to use. Be thoughtful and take a multidisciplinary approach to this.